Now, just after I said we had no eponymous names, like things named after people, so what do we have next? Guillian Barre. Remember, it's always sexier in French. And stop saying Guillian Barre. It's Guillian Barre. And Guillian Barre is the most characteristic thing is ascending paralysis. Now, why we get Guillian Barre is not really known. We know that it's associated with Campylobacter. We know that it's associated with Campylobacter infections, but we're not exactly sure why the Campylobacter infection is doing it. We know that the weakness is going up the body. We know that it's starting out from your toes to your nose, and that basically it's going first from your lower extremities, the ankles and the legs, and it's going up to the upper extremities, and in between there, it hits your diaphragm. So it is an autoimmune phenomenon making antibodies against myelin. Remember that neuromuscular transmission occurs because we are going from point A to point B. And what we know is that we have this neuron here. We know that the neuron is covered with myelin, and that the myelin, we know that the neuron is covered with myelin, and we know that in between these points in the myelin, that we know what happens is that we have saltatory conduction that allows the impulse to jump and go very quickly. We also know that myelin acts like the insulation on a neuron. No myelin, slowed transmission. Not zero transmission, but just slowed transmission, like taking the electrical insulation off of any wire. So what happens is that you develop in this syndrome, you are developing antibodies against that myelin. Campylobacter, Epstein-Barr, CMV, other infections causing IgG antibodies to attack your myelin. It demyelates you. It's acute, it's inflammatory, and it's multiple. Acute inflammatory polyneuropathy. It's acute, it's inflammatory, and it's multiple. It's acute, it's inflammatory, and it's multiple. Acute inflammatory polyneuropathy, ascending weakness. And the biggest thing is you lose the deep tendon reflexes. You lose the deep tendon reflexes. How do you die of Guillain-Barré? By hitting the diaphragm in the middle. It causes respiratory paralysis. So we have two different types of story for Guillain-Barré. One is how do we diagnose Guillain-Barré? Well, the CSF shows you increased protein. However, there's no cells. But the single most accurate test is to take a needle and put it in at position A. You take a needle and put it in at position A. And you take another needle and put it in at position B. You take a needle and you put it in at position A. You take another needle and you put it in at position B. And you stimulate. Zing, brit, zing, brit. And you measure the amount of time it takes for the impulse to go from point A to point B. If you have lost your myelin, that duration is longer. If you still have your myelin, that duration is slower, probably normal. So therefore, nerve conduction studies, nerve conduction velocity, electromyography. Nerve conduction, electromyography. This is similar to myasthenia gravis, except that's not nerve conduction, that's just the electromyography. Electromyography means that point B is a muscle, and you measure to see how long it takes for the muscle to twitch. I put in a needle, I stimulate it, zing, bing, zing, bing, zing, bing. How long does it take? That's an electromyogram. Nerve conduction velocities is just putting a needle on a nerve and a needle on a nerve, and you see how long it takes for the neural impulse to transmit. Now, how do we know if someone's going to die? We do it by looking at pulmonary function tests, forced vital capacity. How do I know that your diaphragm is getting weak? Is inhalation an active or a passive phenomenon? Is inhalation an active or a passive phenomenon? Inhalation is active. The diaphragm must contract, constrict, push down, suck in air. The diaphragm must contract, constrict, push down, sucks in air. Diaphragmatic stimulation requires you to say how much negative pressure, how much suck can you generate? Diaphragmatic stimulation. How much suck can you generate? So therefore, what happens is that if you have the diaphragm if you have the diaphragm and your diaphragm is getting weak, you won't be able to inhale very much. The wrong answers will be waiting for CO2 rise. If you wait for the CO2 to rise, you're dead. The wrong answers will be hypoxia. If you're waiting for hypoxia to develop, you're dead. Forced vital capacity tells me who needs to go to the ICU and be intubated. The treatment for Guillian Barre cannot be explained. Why it is that intravenous immunoglobulins works is not clear. We do think that plasmapheresis works by basically removing all of these antibodies that are attacking your myelin. We do think that plasmapheresis works by removing all these antibodies that are attacking your myelin. So we think that plasmapheresis works by removing all of those antibodies that are attacking your myelin. Plasmapheresis, intravenous immunoglobulins. When the question says, what's the best initial therapy? You'll choose intravenous immunoglobulins because it's easier to do than plasmapheresis. When the question says, which has greater efficacy? The answer is, they are equal. They have equal efficacy. When the question says, what do you do about steroids? The answer is no. No steroids. Steroids do not help. This is a natural wrong answer. It is a natural wrong answer to say steroids. Because you say, well, you just said it's inflammatory. So shouldn't we use steroids? Even my mother knows to use steroids in inflammatory conditions. Yes, she does. Then again, my mother's the chief of rheumatology at New York University. But she knows. So the whole point is that intravenous immunoglobulins and plasmapheresis are equal in efficacy. Intravenous immunoglobulins is easier to do. Steroids is wrong. Combining therapy? Not help. Combining therapy is like wearing pants underneath a skirt. Doesn't help. Like putting a toupee on top of your full head of hair. Doesn't help. Doesn't help. Let's look at our slides. Guillain-Barré syndrome, autoimmune destruction of the myelin. Well, you have an infection. See the Campylobacter? You have an infection, and for some reason we don't know, you have an infection with Campylobacter jejuni. It creates antibodies which attack your myelin. The antibodies are attacking your myelin. The myelin sheath becomes lost. With molecular mimicry basically saying somebody's deciding that these antibodies are attacking something that looks on myelin like it's foreign. The other answer is we just have no idea. Infection causes antibodies against myelin and strips the myelin off. Next, Guillain-Barré, weakness, lower extremities, then upwards. Ascending weakness, ascending weakness. Starts low, goes up. Starts low, goes up. Starts low, goes up. Starts low, goes up. And knocks out your reflexes on the way. How do we tell the difference between this and, say, like myasthenia gravis? Myasthenia gravis starts in the eyes. Myasthenia gravis starts with diplopia. Myasthenia gravis starts with the inability to eat, to chew, to swallow, to eat, perchance to swallow, perchance to digest. Yes, that is the mastication. So, when you have ascending weakness, it is Guillain-Barré. When you start descending weakness, that is often myasthenia, which is in the eyes. The legs are worse. There is a little sensory neuropathy, but it's not the major issue. The lumbar puncture, high protein without increased cells. That's called an albumin cytologic dissociation. Albumin is up, cells are down. Albumin cytologic dissociation. Albumin cytologic dissociation. Albumin cytologic dissociation. Albumin cytologic dissociation. Why did you get a high protein? We think it's immunoglobulins. Why aren't the cells up? Because it's not an infectious problem. The most accurate test is nerve conduction studies and electromyography. We put stimulatory electrodes in and measure the amount of time it takes for the impulse to be conducted. If the nerves have been stripped of the myelin, the impulse is conducted slower. The treatment should be started immediately. Well, how about this? Hi, you have weakness of your legs that has left you paralyzed and is about to hit your diaphragm and kill you. I think I would start as soon as possible. Why, yes, you've captured my attention. You have definitely captured my attention. My diaphragm is about to be paralyzed and I'm dead. Ah, wow, how about this? Do you think any of the patients would go like this? How are you feeling? Oh, it's okay. Both of my legs are paralyzed and I can't walk. But, take your time, doc. Look, this person is paralyzed. They can't move. They can't walk. Of course you should start the treatment as soon as possible. Intravenous immunoglobulins and plasmapheresis are equal, but they are not additive, not multiplicative. They're not additive. They're not multiplicative. Monitor for impending respiratory failure. The monitor is pulmonary function tests. When do you intubate? You intubate when there's a decreased FEV1. You monitor by pulmonary function tests. You intubate when there's a decreased FEV1. That's what we mean by monitor. It means inhalation, exhalation. Can they fully inhale? They're okay. They can't fully inhale? They're gonna die. Intubate prophylactically. That's the end of Guillian Barre.